who will talk about surgical therapies. Thanks, Katie.
Hi, thank you so much, Dr. Cote, for having me here today, and to Caper, and thank you all for being here. I'm going to try to share my screen here. Hopefully that's working.
That looks great, Katie.
Thanks. Good. So I guess in the next 20 minutes, I'm going to do a whirlwind tour of surgical therapy and pancreatic disorders for you. And so in pancreatic disorders, I'll cover tonight chronic pancreatitis, acute pancreatitis, to touch on what Dr. Phillips had to speak about, and then I'll briefly mention pancreatic cancer and just some of the unique issues relevant to that. So chronic pancreatitis, as we all know, is a challenging disorder to treat, and one of the reasons that it's so challenging is that we don't truly understand the complexity of the pain and what causes it, and so it makes making treatment decisions very hard for chronic pancreatitis. You know, medical management obviously is the forefront in this. It's not rushing to surgery, and with that, endoscopic therapies are often the frontline management for patients with chronic pancreatitis. And this is despite several randomized controlled trials that show some advantage to surgery over endoscopic therapies. Now we could, I'm sure with this group, debate this all evening, but just to know that they're out there, the two main randomized controlled trials that show an advantage of surgery long-term over endoscopic therapy. But despite this, given obviously the lower morbidity with endoscopic treatments, this is our first line treatment before we run into surgical management. And the Dutch group did an interesting study where they looked at over 200 patients that had undergone surgery for chronic pancreatitis, and they looked at long-term outcomes, and they found that 68% of patients long-term were pain-free, long-term being 5 years, and 12% had persistent severe pain. And so these are sort of nice guidelines for expected outcomes after chronic pancreatitis surgery in general. But what's interesting about the studies, they showed that high pre-op daily opioid use, as well as high numbers of pre-op endoscopic interventions, were predictive of severe pain. But again, despite that, we still often will send our patients to have exhaustive endoscopic therapy before we go to surgery. So surgical treatment options in chronic pancreatitis, the algorithm for surgical decision-making with chronic pancreatitis really is largely based on the pancreatic anatomy. And so the ductal anatomy as well as the parenchymal anatomy are important. So in general, patients with large duct pancreatitis, that's considered greater than 6 to 7 millimeters in diameter, are really relegated mostly to the drainage procedures, which are known as the Puestow or the lateral pancreaticojejunostomy or the Fry procedure. And then those patients who have small duct pancreatitis have been shown not to do well with drainage procedures. And so those patients are sent for, or considered for a resective procedure in general. And so if they have head dominant disease, such as a inflammatory pseudotumor of the head of the pancreas, or tail dominant disease, with an inflammation mostly in the tail of the pancreas, then we think about a localized resection. And then we'll talk a little bit about patients with diffuse small duct disease who may do better with total pancreatectomy. So first, the classic drainage procedure is the lateral pancreaticojejunostomy or the Puestow procedure. This was described by Dr. Puestow and his colleague, Dr. Gillsby, in 1957. They presented at a major surgical meeting. And then several years later, Drs. Partington and Rochelle presented a modification of that, which is really what we do today. This upper diagram shows a cartoon image from Puestow's original publication that shows they did a little different procedure where they actually put a sleeve of small bowel over an opened pancreatic duct, and they did a splenectomy as well. And then Dr. Partington, which is our more modern procedure, just showed an anterior lateral pancreatic ductotomy. And this is a laparoscopic version of this. You can see here we are opening up the pancreatic duct along its length. And really the goals of the procedure are to do as wide of a ductal drainage as we can. You can see there's a nice stone there that we're removing from the pancreatic duct. You can see it's a very fibrotic pancreas. There's also a little cyst, a pseudocyst, I think I missed showing it right there, that we incorporated into the into the Puestow. And so then this, after it's opened up widely, the limits being medially the gastroduodenal artery, and then laterally we go as far as we can. The limits are to, we drain it with a Roux-en-Y procedure. The problem with the Puestow or the LPJ, lateral pancreaticojejunostomy, is that, I'm sorry, I'm seeing the part, is shown, demonstrated here on these coronal views. You can see on the left side, here's a dilated pancreatic duct with stones and calcium in the duct. That's great for a Puestow, but here's the next image that shows all of the calcium and burden of disease in the head of the pancreas. And this really is not addressed in a classic LPJ. And so that's thought to be the reason for long-term failure from an LPJ. And so in order to address that, Charlie Fry, who's a surgeon out at UC Davis, described his Fry procedure in the late 1980s. And this involves an LPJ, but he also went on to core out the some tissue in the head of the pancreas. And so that's the Fry procedure. And again, this is drained with a Roux-en-Y reconfiguration. And so his description of his first 50 patients had acceptable morbidity and pain relief equivalent or better to the LPJ. And I think what's interesting about the Fry procedure, as to differentiate it from some of the other named procedures, is that it's been shown to be repeated. His favorable outcomes have been shown to be repeated at multiple centers. And so that's notable. So to move on to resective procedures, the pancreaticoduodenectomy or the pancreatic head resection is best suited for patients with an inflammatory pseudotumor in the head of the pancreas. You can see that here on the CT image. This was initially described for pancreatic malignancies, but it was described for pancreatitis by Dr. Whipple in the 1940s. And then the modification with the pylorus preservation was described by Dr. Traverso and Longmire in the 1970s. And this cartoon images shows what happens with the Whipple. It's the pancreatic head is removed, but along with that, the terminal common bile duct that runs through the head of the pancreas, as well as the duodenum along with that are removed, and the gallbladder as well. And then here's the classic Whipple reconstruction, where the pancreas is hooked back in, the bile duct, and then, let me see if I can get this to go back. I'm sorry. There you go. And then here there's an antrectomy has been done, and that's the classic Whipple reconstruction, whereas the pylorus preserving variant is performed preserving the pylorus. Sorry. And then in terms of outcomes for the pancreaticoduodenectomy, for pain relief, again, varied amongst series, but generally very favorable depending on patient selection. The morbidity, however, is quite high. You can see it's much higher than the drainage procedures, where even in the best of hands, it's upwards of about 40%. But in modern series, the mortality is generally accepted to be 2% or less in major high volume centers. And here you can see a laparoscopic pancreaticojejunostomy being done. And so there's the minimally invasive application or approach. So MIS, pancreaticoduodenectomy, or minimally invasive surgical pancreaticoduodenectomy, has had increased adoption over the past decade or so. And it's been shown to have equivalent outcomes at expert centers with multiple single institution and multiple multi-institution outcome studies. Outcomes, however, it's important to interpret them, and that they're really reported predominantly for cases for neoplasia. So for either low-grade neoplasms or more commonly for pancreatic cancer. And in general, if you look closely, most of the cases are not done for chronic pancreatitis. And that's because of the unique problems with surgery for chronic pancreatitis, where there's obliteration of normal tissue planes, the scarring can really blur your anatomy and make minimally invasive approaches much more challenging. And I'll show an example of that with distal pancreatectomy. Okay. So the Bager procedure is the next pancreatic head resection procedure. This is a duodenal preserving pancreatic head resection. This is another procedure that came about in the 1980s in order to try to minimize the morbidity of the Whipple procedure, but also to try to optimize procedures for outcomes for patients with chronic pancreatitis along with the Fry procedure. Again, this procedure in Dr. Bager's hand showed fantastic morbidity and mortality rates and excellent pain relief rates. And he was one of the first people to really talk about return to work as an outcome, as well as improved body weight. The problem, however, is you can see most of the publications on the success of the Bager procedure came from Dr. Bager himself. And so these fantastic outcomes have really not been repeated in other centers. An important trial was a multi-center trial in Europe, mostly from centers in Germany, although a couple other centers were involved. It was a multi-center randomized controlled trial that was recently reported with over 200 patients, and they looked at the classic Whipple and the pylorus preserving variant and compared that with duodenal preserving pancreatic head resection over two years, with 2 years follow-up. And they found overall that there was no difference in major morbidity, mortality between either a classic Whipple or the pylorus preserving variant versus one of the duodenal preserving variants. They did find that the operative time was shorter for the duodenal preserving variants, but readmission and reoperation rates were less often happened after a Whipple procedure. And they didn't see any difference in long-term pancreatic insufficiency or in quality of life. And so in general, it's kind of dealer's choice. And so many centers kind of pick their favorite, many surgeons pick their favorite based on their expertise and experience. So in terms of patients with either tail dominant disease or perhaps a mid-body stricture, a distal pancreatectomy can be an effective means of pain relief for these patients with chronic pancreatitis. This disease pattern seems to be less common than head dominant disease, at least it less commonly presents to the surgeon. But what's been great for distal pancreatectomy is that the laparoscopic or robotic minimally invasive approaches have really become much more common over the past decade or so. And now there are many multi-institutional studies and even a randomized control trial, the Leopard trial from the Dutch group, that shows that the minimally invasive approach has decreased blood loss, length of stay, and morbidity with equivalent operative times and postoperative pancreatic fistula rates to the open approach. And so this has become really the standard of care for distal pancreatectomy. What this shows is that it's not as straightforward as you think, though. This is on the left is a nice laparoscopic distal pancreatectomy being performed for an IPMN. So look how nice and pretty and normal that pancreas looks, and the planes are all pretty, and there's the splenic artery, and they're beautifully preserved. Over on the right is the chronic pancreatitis case. So as you can see, the technical challenges that are presented with chronic pancreatitis cases are much greater than with other indications for this procedure. So what about patients with diffuse small duct disease? And then other indications, what about patients with genetic pancreatitis who are likely to have progression of their disease despite more focal or localized treatments? And then finally, what about patients who have failed lesser procedures? With these patients, we start to think about the next step, and that's total pancreatectomy. Now, clearly total pancreatectomy is a very morbid thing. And so in the 1980s, the concept of islet autotransplantation was born out of the University of Minnesota. And over the past decade or two has really come into a little bit more widespread and accepted use, although the exact indications are still undergoing hashing out. And so the way that a total pancreatectomy with islet autotransplant works is that the patient undergoes total pancreatectomy, and then we immediately place the pancreas on the back table for preservation, just like we would for any transplant. So it's in a cold, balanced electrolyte solution. It's flushed. And then we take it over to the lab immediately, and they perform this islet isolation process that includes both enzymatic digestion as well as mechanical digestion. And then periodically, our PhDs take samples of the islet solution and look to see when the islets are perfectly released from the exocrine tissue. You don't want to over digest them because then they start to fall apart. And then once the islets are still intact but are freed from the exocrine tissue, they're separated just by centrifuge. So we don't generally purify them. And then they're placed in a bag of albumin and heparin along with some antibiotic and brought back to the patient where they're auto-transplanted. At some centers, they keep the patient in the operating room during this time, but that process can take 3 to 4 hours. And so at our center, we generally complete the case and take the patient to the ICU and then perform the islet transplant through a catheter into the portal vein. So what are the endocrine benefits of transplanted islets? In general, there's the biggest, of course, is the endogenous insulin production. So we know that C-peptide can prevent diabetic nephropathy and neuropathy. And then also we've restored glucagon-mediated counterregulatory mechanisms. And that's so important in preventing the hypoglycemia, which is really the morbidity of the apancreatic state. And then finally, we find with these patients, their hypoglycemic unawareness is mitigated by adrenergic responses being restored with islet transplant. And so what about outcomes for TPIAT? We looked recently in the past couple of years at our results with 200 patients. And what we found is that 72% of our patients were women with a median age of 40, and they'd had disease on median about 8 years. 19% of our patients were diabetic pre-op, and 29% had prior pancreatic surgery, so they were salvage pancreatectomy patients. We found an overall morbidity of 59%, which is sounds high, but that's not far off other pancreatic surgeries, and our mortality rate was 1%. Our outcomes with insulin independence were 23% at 5 years, and they were better in non-smokers, those who had had chronic pancreatitis less than 5 years, and those who hadn't had previous surgery. We found improvements in physical and mental health quality of life that was durable out to 5 years in our patients. And the patients that did the best were genetic patients and non-smokers. When we looked at hospital utilization, emergency department and inpatients visits were a median of 0 at 5 years for our patients post-op, and our genetic patients were on a median of 0 morphine equivalents at 5 years post-op. I think that's our single institutional data, and there's great data from University of Minnesota and some other institutions as well. But what we're all anxiously awaiting is our multi-institutional data that we're collecting with the leadership of Melina Bellin at University of Minnesota, where we're collecting prospective data on these patients with NIH funding. So on to acute pancreatitis. I think we had a nice, very thorough view of acute pancreatitis with Dr. Phillips. In general, though, what we're talking about, as she mentioned, is that there's kind of 2 phases in severe acute pancreatitis. There's the early phase where it's really dominated by cytokine-mediated organ failure. And that's really not what we focus on in surgery. This is generally relegated to supportive care for these patients. But we really look at the second peak of mortality, and that's what we're hoping to intervene and to make better in patients with surgery and other interventions, is that second peak of late mortality after 4 weeks or so, where patients have problems with secondary infection of necrosis and sepsis, and that's the reason for mortality. And then again, Dr. Phillips talked about the revised Atlanta criteria, and we're really talking about patients with walled-off pancreatic necrosis. So again, just to reiterate this, the most important thing in debridement and outcomes that we've discovered in surgical experience is that timing is everything. So very early on in surgical experience, we would do early debridement. We found a very high morbidity rate. But Dr. Fernandez de Castilla in Boston showed us in the late 90s that delayed debridement. So if you can delay your debridement out to 4 weeks and get beyond that initial SIRS response, then you can really decrease morbidity and mortality. And then what about who to debride? We really want to debride patients with infected necrosis, and then those patients with sterile necrosis that have what Dr. Warshaw has coined as persistent unwellness. So those patients who are not getting better and are not going to get better without intervention. So then we get on to the interesting part is, how to debride. And there are so many different approaches in the modern era. And as Dr. Phillips explained, that we really want to try to do a thorough debridement and treat our patients well with minimal morbidity, but we'd also like to do it with the least morbid approach. And so there are percutaneous drains, there's endoscopic debridement, and then I'll just touch on surgical debridement for patients. So open debridement, you know, is the classic, I think should be considered the gold standard for debridement of pancreatic necrosis. And so this is generally approached with a laparotomy. There's access to the lesser sac gained by the surgeon's style. We generally go through the transverse colon mesentery. And then there's a blunt debridement and irrigation and placement of large bore drains for postoperative lavage. I think what's important to think about as we look at outcomes for open debridement is that there's really no great data on open necrosectomy in the modern era. So much has been replaced with minimally invasive approaches that I don't think it's a fair comparison. We have some great single institutional data, but even that's, you know, greater than 10 years old. And so I think there are definitely still cases where open necrosectomy is the absolute right thing for the patient. Although obviously if we can avoid it, we'd prefer to have a minimally invasive approach to avoid the morbidity. So we talked a little bit about VARD, or video-assisted retroperitoneal debridement, also known as the step-up procedure. This is described in our country initially by Horvath, who described this in the early 2000s as again, the videoscopic approach to the retroperitoneum. And the advantage being that you stay out of the primary peritoneum and you go minimally invasively. Let's see. And so the concept with the VARD is that you place first a percutaneous drain, and the step-up concept is that for many patients, a percutaneous drain is enough. But then if there's persistence of necrosis, then we use that drain as a guide to have an intracavitary videoscopic necrosectomy. So I won't go back over this study. This is the same study that, that Dr. Phillips showed earlier, the step-up study that shows an advantage to the VARD approach over the step-up approach over the classic open necrosectomy. I think I will point out that the mortality was equivalent, while the primary endpoints of major complication, such as new onset organ failure and hernias and other things like that, new onset diabetes, were lower in the VARD. So what about other approaches? The transgastric debridement can also be done surgically. This is very much like the endoscopic approach. It really draws on the surgical experience of the cyst gastrostomy. So this is a laparoscopic version you see in the video, where we went in laparoscopic and made an anterior gastrotomy and then make a posterior gastrotomy to get into the necrosis cavity. And the nice thing about this compared to the endoscopic approach is that we can use a little bit bigger instrumentation and can do it all in one 30-minute procedure rather than having to do multiple endoscopic events with these patients in order to debride them. And you can see we can get large volumes of tissue in one sitting, which is pretty satisfying. The disadvantage compared to endoscopic approaches is that our instruments are pretty straight and we're a little bit limited by angulation. And so that does decrease our success. I'll mention that the added benefits of transgastric approaches in general, including the endoscopic approach, may be that we create this fistula to the stomach for the disconnected left pancreatic remnant. So maybe we're preventing a long-term complication of pancreatitis by allowing for that disconnected left pancreas to have an outlet for drainage. There's been a lot of conversation about disconnected left pancreatic remnant. I think that the data on this is limited. Classically, the management of this has been a distal pancreatectomy for patients who have persistent problems with this. You can either do it acutely during debridement or delayed down the road once the cirrhosis subsides if patients prove they have continued problems. And we've actually taken these patients that have a significant amount of viable tail tissue and harvested their islets and auto-transplanted them after distal pancreatectomy. And then, of course, the other management that's emerging and is really being investigated is what's the role for long-term transgastric endoscopic stenting for these patients. And so for acute pancreatitis and pancreatic debridement, there are multiple approaches in the modern era. But the idea is to control the source of sepsis, decrease the necrotic tissue burden, and minimize our pro-inflammatory insult with our approach. And then finally, just for a minute, because I'm out of time, I'll talk about pancreatic cancer. In general with this, for pancreatic cancer, as we know, for patients with potentially curable disease, the treatment options are surgical resection and systemic chemotherapy. And so in surgery, we look at patients primarily that are resectable locally and without distant disease. In these patients, we consider neoadjuvant therapy and then onto surgical resection. And then the other group I think that have really emerged and are of great interest to us are the patients with borderline resectable disease. These are patients classically thought of as having anatomically borderline resectable disease, meaning they have vascular involvement. And these patients we often try to treat with neoadjuvant therapy to optimize our surgical success. Borderline resectable considerations, in addition to anatomy, are patients that may have a high CA19-9 or maybe some tiny amounts of disease we think may be indicative of aggressive biology, or patients that have poor physiology. And then we look for preoperative planning with these patients. Our biggest concerns, of course, that make this surgery for this approach a little bit different are the vascular anatomy and the relationship of the tumor to the blood vessels. And so in these patients, we do a similar Whipple as we do for chronic pancreatitis, but we think about our vascular resection, and that's when it becomes more challenging for these patients. And so in conclusion, for pancreas surgery, for all pancreatitis and for cancer, there's lots of art and not a lot of science. Patient selection is key. Pancreas disease is morbid, and minimally invasive surgery is the future. So with that, I thank you for your attention. I'm happy to take any questions.
Thank you, Katie. That was that was fantastic. If I could ask Katie and Anna to unmute their Zoom so that we can see and hear you. If anyone has any questions, we have a few minutes to ask our two speakers your burning questions about acute pancreatitis and about pancreatic surgery. I have a couple of questions that came to mind as I was listening to these great talks. The first one is for Anna, which is in regard to the nutrition plan. So this is always something that we try to think of relatively early in the course, but the classic teaching is that you have to place a nasojejunal tube for patients, so get it down well past the duodenum so that the pancreas isn't stimulated. But for those that have ever placed these or managed these tubes can be difficult to get in place, keep in place, and prevent from clogging. So, Anna, what are your thoughts about feeding the stomach directly, or what we do many times is place Dobov tubes, which effectively feeds the duodenum? Could you tell us your guys' approach at UPMC as far as enteral nutrition is concerned?
Absolutely. And so the preferred method is definitely to place a nasojejunal tube if able. They're often placed endoscopically. And so as soon as the patient is thought to be stable enough to undergo an endoscopic procedure to place a nasojejunal tube, the nasojejunal tube, as you alluded to, it achieves several goals all at once. And so it achieves a course of pancreatic rest for patients. In other words, the idea is that if you deliver enteral feeding well past the ligament of Treitz, you are going to minimally stimulate the pancreas over the course of nutrition after the acute event. The thing is that there have actually been several trials trying to directly compare nasogastric and nasojejunal tubes. And trials have not shown clear superiority of the nasojejunal approach in terms of outcomes, whether it be morbidity or mortality for these patients. And oftentimes, many patients are able to tolerate even standard enteral feeding into the stomach. And so most recent guidelines from the American Society for Parenteral and Enteral Nutrition actually recommend these two techniques almost equally. And so if patients are not able to undergo placement of a nasojejunal tube, it is possible to place a nasogastric tube and at least attempt feeding there and redo placement of a tube further distally if patients aren't able to tolerate it. The most important, I think, is to deliver enteral nutrition however you're able to, in order to maintain that gut barrier to prevent translocation of bacteria and deliver calories.
Great. Katie, a question's come up that I think would be best for you to answer first, which is, in managing necrosis, aside from the patient who's, you know, end stage multi-organ failure, who needs a percutaneous drain sort of urgently, how early can you activate any of the approaches, surgical approach, endoscopic approach, or a percutaneous approach, to start the process of debriding necrosis? When do you, what's your timeline in that, on that issue?
Yeah, I mean, I think in general, we try to wait as much as we can. I think, you know, indications that would make us try to go sooner would obviously be clear signs of infection. And then the second consideration, we talked about a little bit about, or I talked a little bit about persistent unwellness. I mean, what you don't want to do is go beyond the window where people get so far gone nutritionally, in particular, that you end up missing the window to make them better. And so typically the classic time that I really think hard about is the sort of 4-week mark is what I aim for. And so in general, we do what we can to let patients evolve and to see how much they mature over the first 4 weeks as much as possible. And then at the 4-week mark, we say, okay, can we go longer? Are they making improvements? Is this someone who's maybe going to fly? Are there major factors that make me physiologically not want to intervene on them? But then again, I also don't want to miss, if it's clearly someone who's at some point going to need debridement, there's often not a great reason to wait much longer than that.
Yeah, and I'll just comment from the endoscopy side that I think sometimes if you jump into these cases a little bit too quickly, you start sooner, but you actually drag the process on longer. The debridement is less efficient, at least with the endoscopic techniques that are currently available, because of the lack of maturity of all the walls. And sometimes we can make matters worse by infecting secondary ascites and so on. And so it really is, this is a good example of the art of medicine and trying to pick that sweet spot where you don't wait too long, but you don't pull the trigger too quickly, and intervene on someone who may not need any intervention at all.
Yeah, you know, it's so funny that those endoscopic studies looking at early intervention really mimic the exact surgical experience. You know, when I was a surgery, or when I was a medical student and an early surgery resident, we would debride early and take these patients back every day and do a towel clip closure and debride them. And it's very much like some of their early endoscopic experience. And so it's interesting to see.
Mm-hmm. We try not to follow the surgeons, but sometimes we do.
I know it's a rare example.
Last question is for Anna. It's a great question. Anna, you have a patient who has acute pancreatitis. They recover from the episode. During the hospitalization, you know, you do the usual workup for etiologies, gallstones, alcohol, metabolic etiologies, and medications. Nothing is really obvious. So now the patient is coming back to your clinic. Give us your sort of bullet by bullet. What are the things that you look for, let's say after one episode for a patient, and then for another patient who maybe you've met after their second or more episodes?
In the first scenario, where a patient has had one episode of acute pancreatitis and a clear etiology has not been found, I of course want to make sure that everything has been sent and resulted. That'll help me to determine whether or not someone has a clear etiology. And then I kind of use a rule of thumb that everyone gets one free episode of acute pancreatitis, but no more than one. And once patients have a second episode, a further, more exhaustive etiology, etiological workup needs to be completed. And so therein would include additional genetic studies and other evaluation for structural abnormalities and other metabolic causes, rare medication side effects, et cetera. The most important thing once you have a recurrent episode of pancreatitis is that these patients are now on that spectrum that I mentioned earlier, where patients, when they have recurrent episodes of inflammation, are starting along a possible progression into chronic pancreatitis, from which there is usually no return. They may, if you're able to stop that progression, not progress further towards chronic pancreatitis, but you can't go backwards along that spectrum. In patients who have recurrent episodes of acute pancreatitis, I'm also screening over time then for some of those more long-term effects. And so annual evaluation in patients with recurrent acute pancreatitis for hemoglobin A1C levels, evidence of exocrine dysfunction, even things like vitamin D deficiency or osteoporosis further down the line when patients have some degree of either early chronic pancreatitis or evidence of fibrosis are things that I would usually do on an annual checkup basis. I think the other thing to remember is that in some patients, especially older populations who are going to be at higher risk for pancreatic cancer, if they have a family history or something like that, it'd be important to remember that about 10% of pancreatic cancer patients are going to present sentinelly with acute pancreatitis. And so keeping a low threshold and a high index of suspicion to look for that as a potential contributor is also very important.
That's a great point. Thank you, Anna, and thank you, Katie, and thank you all. So we're up against our 1 hour time limit. So with that, I will close and thank you all again for participating tonight. Please remember these lectures and discussion will be available on the CAPER website. And please complete the post-assessment test so we can make sure that we're doing a good job of educating you all on issues of the pancreas. Thank you all very much. Have a great night.
Thank you.
Thank you.